Okay, now I've unmuted. Good morning, good afternoon, everybody. Well, thanks for the intro, Nick. Director of a company called Integrated Healthcare Properties. We're doing this presentation jointly with Socitm, primarily because we have some experience in estates and expertise in estates and funding. But what we're focusing on today is what's really quite dynamic in the market, which is how estates and IT can work together, especially around hubs. So that's all part of this program Socitm's running of building successful integrated care systems. Moving on, there's two parts to the presentation today. I'm carrying out the first, which is really just a little bit looking at some of the global systems drivers which are out there, which are important for the general place settings or match down into individual hubs. There's a couple of issues relating to tomorrow, i.e. the next 10 years, which probably aren't on the radar today, which should be incorporated within hub planning. And we've given a couple of examples of what we've done in terms of systems and also in terms of ICS hubs. So trying to make it practical. The focus of everything I'll be saying is a little bit of background to say we can do some of this, but really I'm trying to bring out where estates and IT interlink in relation to hubs. And then Russ will take you into more detail around what's happening in IT and actually more of the exciting stuff, I would say. So let's just start, shall we? This is all about global systems drivers, as I said. And the first place to start is what our vision is, what we're trying to achieve as two organizations. Effectively, we're trying to establish 21st century health and social care facilities, which are equally available to all residents within a place setting, whether that be 200,000, 400,000 or larger ICSs. And we're looking at where the IT and estates can take some of the opportunities which are there, which are coordinated. And the key thing which has been driven out of this presentation, as you'll see it go through, is all about flexibility. How can it adjust to some of the changes which are happening now or some of the changes which will happen in the future? There's more words in a lot of these presentations I won't bother going into, but there is a myth out there that you've got no capital, you have no options, you have to do very small incremental changes to your estate, normally related to priorities. I don't believe that's the case, and I don't believe what we've done in the past actually shows that's true. You have options. The example I use is Newham, where a community and primary care estate is going to benefit from some £200 million worth of investment over the next 10 years. And they've started building some of these things now. It needs a plan, but it is possible to achieve this in an affordable manner, in a collaborative manner with the various ICS partners. So moving on to the next slide, we're going to start talking about smaller areas, which are the 60, 80,000 people who are serviced by hubs. Now I'll take questions or comments as you go through, but we do have a part at the end where we'll wrap up on this. I'm not going to dwell on the today issues, some of the visible things which you're seeing. There's a big debate going on about how much physical versus virtual consultation there is. Is it 40, is it 50, or according to the press now 75%? Oddly enough, the best example I've ever seen is one of the practices down our way in London, where they actually do 40-odd% physical consultations, but 100% triage. And we're doing it prior to COVID, but they spend a lot more time with the patient than what is the normal NHS standard. So they're achieving outstanding. Russ will take you through the fact that is it just virtual telephone calls, or is there something more which can be added in a IT estates environment which will enhance the contact with the patient and the contact with the practitioner. And the other thing which is pretty relevant at the moment is PCNs are new. They've got quite a few new responsibilities, but they're falling down because the infrastructure availability isn't there, whether it be estate, they're trying to fit them into some of the existing sites, or whether it be the estate and IT. That we'll touch on because we've done some work around how you can design certain of these hubs to make that IT and estate interaction work for the PCNs. The real interesting thing is there's a few things which are actually new coming on the horizon, which probably haven't been picked up as much in some of the work which has been done concurrently. And this is why I'm saying whatever solution comes up from what we present today, or ideas come up, it has to be flexible to change because things are going to change, and they're going to change quite dramatically. There's, in private equity in America, they spent something like $14 billion investing last year in new stage, early stage innovations for healthcare, whether that be an app, whether that be a type of diagnostics, whether that be 100 different things which have been invested. And that's just America. About 100 billion is getting invested across healthcare, and it's going up 50%, 100% per year. What that means is there'll be a raft of new types of way of contacting with patients for practitioners to be supported over the next 10 years, starting to appear as products and starting to enter the NHS. The other thing which is coming in the horizon is we have quite a few PFIs or CHP buildings within the estate. Certainly down in London, they're a little bit expensive or very expensive. They may be coming back into the NHS at the end of term, or different terms may be negotiated with the provider. Those types of buildings, many of them are actually quite well located and quite substantial, and therefore they could be useful choices for the types of hubs we're going to talk about today. And then finally, zero carbon, it's an NHS target for the community, and there's ESG funding. Both of those things are likely to be litmus tests for whether a project gets approved or doesn't get approved over the next 10 years. Can I have the next slide, please? Please read this at your leisure. We did some hard analysis a while ago on estates and on IT, and we identified a number of drivers, why people want to change, and a number of barriers, why you're finding change quite difficult. Now, we've adapted what we do to try to deliver the drivers and to overcome the barriers. But in terms of the IT in relation to place or hub, both these things exist everywhere. You can't do a new hub if it's not affordable. The fact that you have a ownership structure of the physical estate in various hands means it's quite more difficult to move them onto a new facility. The IT interoperability is also a key requirement for making these hubs work, as is partnership. Staffing issues are a huge thing, and getting people to work together is massive. There's no point putting them in a building where they're all on separate floors and the communication's not great. They own each of their own individual areas and they don't share. Something has to change, and something has to change in the way it's presented and made flexible for them going forward. The next slide, please. So I'm not talking madness, okay? I mentioned the fact that we've done one which is 200 million investment in Newham. That's on the left-hand side. It's a joint venture, locally owned joint venture between the NHS and the local government. They weren't very happy with the state of the properties within the borough. There were a number of GPs who basically were in unsustainable buildings. Both those parties came together with the help of IHP in terms of presenting and developing the model, and they've set up a joint venture which has a project stream of, I think, 12 new builds. The first one, which is pictured there, is now up and operational, has been from earlier this year. Because something can be done as long as you've got the right plan and you've got the right sort of collaborative spirit. On the right-hand side, this is what we want to talk about. This is a ICS hub. We did a SOC earlier in the year on a 80,000 population solution, and it's the first time IHP and Socitm worked together. We also worked with architects, QSs, and analytical companies as part of the team to work out what we could do. It was fairly substantive. It's about £40 million spend, and we were asked to look at it because there was a big funding gap. The key thing is that little diagram there. That shows the different levels of the floors which have been presented, designed. The middle floor is using something called a on-stage, off-stage approach to healthcare, where a number of the clinical rooms of a different sort are consolidated, and wrapped around that are the patient waiting rooms, and wrapped around that are the front-facing clinicians. The benefit of that is you can have a mix of rooms in there which are just not standard GP 16-meter, you got a bed and a desk, etc. But you can have MDT rooms, you can have interview rooms, you can have the PCN working and actually providing some of the services from those types of facilities, and bring in the acutes if they have to be represented physically within the building, and certainly the community services. Where the link with the local government is, it can be in terms of public health, using that facility for some of their group meetings, but quite a lot of it is in terms of IT links to them through the MTT, and IT links to them through the patient within the waiting rooms. So this is a highly IT intensive environment where people can actually work together. The shared areas in terms of back office, which is relatively little, in terms of restaurant, leisures, etc. But the benefit of on stage, off stage, from studies in America where it's started to be used more extensively, is you get about 20% saving in terms of how long it takes people to flow through that system on either side. And the aim of that system is to ensure that people who work there, the practitioners or the clinicians, actually have points of contact where they can engage with others. So you're starting to try to build that collaboration community spirit at that particular level. Given that that's the centre of excellence, it's got some good IT, it's got some decent diagnostics, what we use the hub for is to emit from a central core. So the central core of this 80,000, about 35,000 from memory, 36,000 was actually GP list size of a number of practices consolidated onto the site within the same PCN. It then had a remit of supporting the other PCN members further out. So it took it to about 60,000. It also supported things such as school visiting, maternity, etc., which falls within that catchment. And then there was a final push out to about 80,000, where they could actually send people in for community diagnostics. Okay, so the services were there and the broadband length capacity was there. So it's basically you're not repeating the same sorts of spend or technology in the different areas, but you're allowing them to connect into it. Therefore, it's relatively efficient, and each of the participants feel they actually have access to a facility which they will benefit from. The final quirk on this one was, because of one of the HIP projects, they asked if we could look at a variation with a UTC. And so, yeah, we added a UTC, in which case it would have gone beyond the 80,000 and basically followed the catchment area of the acute, which they were thinking of relocating. But to emphasize from an estate's perspective, this is all about us working with the patients and working via IT to host physical visits and also to host remote consultations of multi-parties. Moving on. I can take a lot of questions now. On the left-hand side, there's just some information on AFOs, which I don't want to dwell into, because this is all about the right-hand side. What I said previously, this is best practice as far as we can see. The ownership of who does a hub is irrelevant. It's supposed to be and do what it has to do. It's a reminder of we're operating a hub and spoke satellite system, with central facilities. It's a reminder that we've got widening catchments going through so that it is efficient and yet it's still accessible. We talk about virtual plus interoperability. Socitm will go into this in more depth. There is a real ability through the type of information flowing, through the type of ability to bring people in each 6 months for long-term condition review, etc., through the ability to work with them directly at home, that you can actually start to change the way you interact with your resident base to improve the quality of their healthcare. And as I mentioned, the clinician space improves the efficiency of the interactions. It enables PCNs to work. And most importantly, we're not building rigid structures on these floors. We're laying down enough IT that we can flexibly move things as is required as new innovations start to come through over the next 10 years. I think at this stage I'm handing over. I think you've probably had enough from me. So if there's any questions before I hand over, more than happy to take. If not, we can wrap them up at the end.
Okay, thank you, Andy. If anyone has got any questions for Andy, if they want to jot them down in the chat or pop their hand up, that'd be great. If we've got a question maybe for people who are here, you might want to have a down and again jot down some answers in the chat. And that's around how primary care networks in your areas, how they're finding the space they need to provide the services that they have to provide, and whether the solutions they've got are sustainable. If that's something that people want to think about, maybe jot something down in the chat. I think generally people can get, no offence, Ross and Andy, people can sometimes get at least as much out of the chat between themselves in the sidebar than they get out of the speakers. And I suppose maybe one query I've got, Andy, Russ, you might want to come in on this as well, is about how, as well as sort of health partners, how you would look to include local government, third sector, other sort of organisations in the hubs?
Well, I'll take my bit first. Well, the first thing is you wouldn't, a lot of what the local government does, they do directly from offices or they do directly at care at home. So they're not physically bringing as many people into their sites as they normally would do. There is no point bringing local government physically onto a site, which is relatively expensive, if they can continue to operate like that. So this is added value. The one thing local government said to us is they want us to be able to connect from these hubs to themselves, the housing, the other types of issues, and also to the third sector. So we can do that quite a lot through some of the virtual things which we're putting into the waiting rooms, etc. The MTT rooms, we can bring them in. And also there's programs of looking, as I said earlier, long-term care, that sort of thing, complex conditions, where you might actually use this hub on a regular basis to basically have a health check, a valid health check on these individuals, which you're then following up on a regular physical visit from the local government to the person's home, etc. So they don't want to be here big time, but they want to be able to use the facilities. They want to be able to connect with the people running through, and they'll definitely get that out of a hub. Public health, which is a big thing, would probably use this much more than others, just simply because you arrive and you can actually see this is a statement.
Yeah, in many ways, you stole my thunder on that last point. I can think of two things off the bat where local government should and are interested in these hubs. Your second point around public health in terms of some of the prevention campaigns that they're running, which are about understanding local populations and dealing with some of the long-term condition issues, many of which got exacerbated over COVID. So I think there's something absolutely there about sharing data and sharing services differently. And I think the second piece of that is, local authorities past masters of dealing with resilience at a neighbourhood and place level. And I think this is where the rubber hits the road for hubs. This is, dealing with a lot of the reactive care, but also some of the planned care that's now featuring in many of the ICS's plans around outcomes. And, we're a firm belief that hubs can be, one of the main, if not the main, one of the enablers for, the delivery of different care models, which I'll touch upon when I have a chinwag later.
Okay, brilliant. Thank you, Russ. And Russ, I'm aware that I didn't give you an opportunity to introduce yourself earlier, but I think if there's no questions from any of the participants, that if we now roll straight onto your part, maybe you could introduce yourself in that.
Yeah, of course. So, thanks once again, everyone, for joining us today. I hope you're going to get something out of it. I'm Russ Charlesworth. I look after integrated care for Socitm, and I'm going to spend a bit of time just introducing what the digital and IT aspects that are now going to be part of the hub thinking and why they're important. Perhaps I can start with this slide, which is, whenever you embark on any of these sorts of initiatives, you kind of think, what is the core exam question? What is the core thing that we're trying to do here? Well, it's the opportunity to change the health and care experience of individuals at a local and place level. That's really what it boils down to. How can we galvanize the developments in property and the way that estates thinking and intelligent building design has come together? How can we harness what's been happening in terms of integrated local workforce with all the issues that we'll be aware of around capacity gaps and trying to land joined up services with locality teams and neighborhoods? And then the third area, so the third corner of the triangle around digitally integrated care services, which is the bit I'll place a bit of time on today. What we've learned as a sector is that the dysfunctional aspects of us accessing services locally about breakages in general. They're about breakages in data, breakages in communications between various services, an inability in many cases for us to do things for ourselves, and for those unable to actually care for themselves, to have someone coordinate once without repetition and rework at what's going on. So if you look at that as the kind of core problem statements that we're trying to solve, I try and reflect on how hubs coming together with these three sets of enablers will make life different going forward. I'd be sitting here with many of you, I think, as I know, have been involved in health and care facilities for some time. You might be saying, well, hold on, I recognise a lot of this. This is not new. We've had these sort of attempts at putting these buildings together before, ISDCs, lift, yada, yada. What's different this time around? I think there are a few things that are different, and I've attempted, and this is not a exhaustive list, but I've tried to pull out what I think are the main ones. So plumbing, probably more better put in technical and digital language, as infrastructure. Hubs can now piggyback on a lot of the investment and infrastructure that's been made over the last 5 years. Now, it's not finished and it's not complete and it's not perfect, but if you look at the list of investment that's been made in technical infrastructure that's available now at a regional and local level, the investment in web services from the NHS in Spine around identification so that you can move around the country and access care records, regional infrastructure in what was originally the local health care record from 2017 onwards, and more latterly the shared care record, and a lot of the behind the scenes activity and interoperability, getting open standards. That journey's not finished, but it's made lots of strides. And also some of the techie stuff. Hybrid cloud is in a very different place than it was 5 years ago in terms of its affordability, but also its resilience. So there's lots around the plumbing. Tools, we've all been using the tools differently over the last 2 years with COVID. Personal efficiency tools, Office 365. Andy mentioned triage, digital triage has come on leaps and bounds. the ability to intelligently schedule. How many, either on a personal level or friends and family, have been to care facilities once on a Tuesday for a flu jab, second on a Thursday for a falls clinic? Why couldn't they have been coordinated so that the person is making one journey? And what aspects of that could have been done remotely? So there's something around intelligent scheduling and tools. Data, I'm not going to lean too much on data. We've got another webinar coming up next week on this very topic. But health population analytics, you know, that's in a very different place to what it was when I was doing this stuff 10 years ago. You know, place-based data and the opportunity to harness a person's personal circumstances. You know, the Achilles heel of how do you deliver personalization. We are starting to get there now. We're starting to build up rich data about people and, you know, including, you know, IoT in terms of people in both residential care and dom care, with, you know, biomed sensors, motion sensors, energy sensors, building up a profile to keep people safer and to deliver the services that they need. COVID recovery, well, I'm not going to say too much about that, apart from, you know, remote consultation experiences for across the health and care professions, from OTs through to GPs, you know, without degradation of care, with some change, but without degradation of care. You know, it went from, you know, 20, 30 up to 90%. And, you know, many of the practitioners and many of the public we speak to want these new ways of working to stick. So COVID recovery will need to make sure that things that worked carry on working. Social care reform, well, I'm not going to touch on that too much, but, you know, one of the things that will happen apart the care cap is that prevention-based social prescribing, social prescribing has been around for a while, but that will grow and it will develop to satisfy some of the self-pay aspects locally, and also some of the Eligible Care Act individuals. Affordability and flexibility, I think of all the changes, this is the big one. You know, when we looked at you know, kind of some of the digital services and IT services, even from 5 years ago, relatively basic to what we've got now, and from an affordability point of view, perhaps weren't as affordable as that. You know, we might have all been in some of these hub centres over the years, lift buildings, where we walk into the building and there's a reception desk, possibly two. And on that reception desk, how many desktops or laptops are sitting there? Definitely not one, sometimes two, sometimes three. And the reason is that they've got multiple services and multiple tenants in those buildings, and they have to log into one system in order to find out where you need to be in the building, where that consultation is taking place. You know, that's all behind us now, should be behind us now. We can integrate this both from a self-service point of view and also from a coordinated service point of view. The last one I'm going to touch on in the next slide, which is digitally disruptive care models. So if we could go to the next one, please. So again, here's a few factors. What do I mean by a digitally disruptive care model? This is about changing local services and how we consume them. So the first one, care outcomes. You know, we've talked as an industry about outcome-based commissioning, to my knowledge, for 20 years. You know, it's a recognised need. Andy picked up on public health and their role in all of this. You know, if you boil down their primary purpose in life, it's around disease management at a regional, local level, and also how to deal with long-term conditions. Now, what that has done, and this is where the technology pieces come in, is it's spawned many new digital innovations around prevention. So we can see, you know, different screening methods for bowel, breast. We can see the ability to consult online, monitoring solutions. As an organisation, there's many, but this one I'm familiar with, Healthy.io. We're doing lots of home-based tech around COPD, blood analysis, UTI, etc. So care outcomes are starting to be integrated, not just from a treatment point of view, but with prevention as well. And that's the crucial bit here. It's bridging treatment with prevention, and that will give us a different experience. Now, as I say, digital enabled working, we've all recognized that. For a long time, we thought that the deployment of these technologies was going to be, you know, going to take us a long time and it's going to be difficult. Well, guess what? In a few weeks and months, we started digitalizing home working. we started doing remote consultations on platforms. Yes, there were hiccups, but we got through those. We've now got more sophisticated things going on, virtual hospital and care ward rounds by videos. This is empowering individuals to do things very differently. This is a disruptive care model. Reimagining digital services. Now, we did some of this during COVID, and frankly and openly, we had to, we had to do some shortcuts to get there. The nub of that was, how are you going to engage citizens in some of the design and the redesign when they're shielding or remote? So some of that had to be done by people making professional judgments about how digital services and pathways could be created. And for the most part, they worked. They will need to be enhanced as we go forward. But, a lot of things did change. The change of community services to accommodate outpatient shutdown. We know that the number of referrals into that was, dropping off a cliff. And local government did take a lead in some of this community resilience, as I talked about, and they did redefine and is currently redesigning a lot of these place-based services. And the last point I'll make on this, and there's one more slide after this, is improve local collaboration. We all saw that the NHS and local government worked together in different and productive ways over the last 2 years. Lots of shared purpose. And that was at a locality and neighbourhood level. We saw joint action to support rough sleeping. We saw targeting proactive care around shielded populations. Remove some of the constraints, again, we're all familiar with, around joint funding. They got brushed aside. Will they last? Not always. Will some? Yes. Trusted assessor processes, improved discharge, community support. Some critical might say, well, that was to get them out of health settings into care settings to remove the problem. I think more supportively, a lot of good work happened there. And I think, one of the things we want to do, and these hubs will contribute to this, is to reduce the inequalities, including digital inclusion, that remain in populations and communities. The last point I'm going to pick up on is this one, which is around the next generation. If you think about hubs, when we traditionally thought about hubs, we thought about buildings, bricks and mortar, where people would go, as Andy says, in populations from 60 to 400,000, depending on scale, and you would consume your services there. I think what we're thinking about now, and what I would encourage you to do, is think about hubs as a hybrid, the ability to consume services digitally, and for that to be coordinated as in conjunction and in close contact and tandem with physical services, whether that's one-to-one consultations or whether that's in group consultation. And I think that's now the really big opportunity here. So, ICSs are going to have the same dual challenge as what we currently face: aging population, increase in the frequency of chronic diseases. Yeah. So that's not going to go away. People with 2 or more comorbidities. What digital and physical hubs will start to do is be able to ration and challenge the services and the availability that we've got in a very different way. Go back to my original point. This is all about quality of life improvement for people with dependencies, including their families and carers. Maintaining people to be able to live longer in their home environments, increasing their independence, improving situation of people that have got both support and self-support. So, we're expecting, and I think this is where the critical buy-in and the leap of faith from commissioners and practitioners and politicians is, we're expecting some efficiency improvements from digitally coordinating care, and that's going to help with the affordability and getting these schemes over the line. So it will develop more practical personalisation, because we'll have the data and we'll have the means to be dealing with that from a self-management point of view. Digital triage is not new, but we can do this in a coordinated way, as I say, across treatment and prevention, and that hasn't been done well to date. And that will improve and shorten lines of communication between care professionals themselves, but also between care professionals and reducing the number of referrals that are associated with that. We touched on workforce, but I haven't really said much about it. But I think, in talking to people across the systems, one of the things that they all want is to be more proactive, but they just don't have the space to be able to do that. They're absolutely knee deep in being reactive. I think if we can get some of this prevention activity, digital prevention activity put into place, it will reduce reactivity. It will reduce, some of the known common problems across the whole system for both working age adults and for frail and elderly. UTI reduction, improved hydration, falls reduction, improved medication adherence, lower primary care, contact. I know all PCNs are very interested in how they can leverage their capabilities through these hubs, and very timely inoculations, winter flu jabs, improved bowel screening. If we can proactively use these hubs as a way of getting information out rather than just expecting inbound, then it will change the experience we have for health and care consumption locally. Anyway, I'm going to stop there, and I'd be delighted to take any questions or points that people want to make.
Okay, that was great. Thank you, Russ. I think there was a huge amount there from both Russ and Andy that starts to illustrate some of the challenges, the change and complexity of the situation that you all find yourselves working in. Is there anyone got any questions for Russ, questions for Andy on what they've just spoken through? And again, if you don't want to shout them out, just pop them in the chat. Alex, do you want to?
Thanks, and thanks for both presentations. They were really, really helpful. On the IT front, and I appreciate I'm not totally familiar with the different setup around technologies in England. I work for the Welsh Government. How much was needed to join up the different systems? How much new digital development was required in that space? Because one of the challenges we face is basically all of the different pieces of software don't talk to each other, so there's no middle ground, and you make progress on joining two up, but you've still got 500 more that you've got to work out how they fit together in order to deliver those outcomes that you described. So we're really interested to hear about how you broached that and some of the challenges encountered.
Yeah, Nick, I'm happy to take Alex's question. It's a brilliant question. So I think we, and when I say we, I mean me, glibly talk about piggybacking on some of the tech investment that's already been made. I think perhaps not the most helpful answer, Alex, is say it does vary region to region. Okay. So in very practical terms, what we're trying to do is to say, if hubs could piggyback from some of the infrastructure, and what I mean by infrastructure, I mean the interoperability platforms, which I think is the point that you're making. You typically see anywhere between 5 and 10 existing IT systems that will need to be pulled together. Example of that, the GP system needs to talk to mental health, needs to talk to community, and then the social care system for case management, etc., etc. The good news is, although it's not complete yet, is the heat map of what's going on around the country, and I'd be interested in how things are progressing in Wales, is in a much better position in 2021 than it was even 3 years ago, so the piggybacking is a reality. When we were doing the strategic outline case, I was actually really pleased about being able to red line through the things that I thought were going to go into the business case. You're going to need one of those, you're going to need one of those, and we already have that. So we already have that within the region, and what we will do is then treat the hub as another node on the network. So in the same way as we've connected up acute hospitals with mental health, the way that we've connected some of the primary, a lot of that technology is already there. But I think, I'll stick with my first answer, which is it does vary region to region, and that obviously affects the affordability case for each of these hubs, because if a lot of the investment has already been made, and a lot of it has, then it is piggybacking, and therefore it's incremental cost over and above what's already been a sunk cost effectively. But it's generally where there's a good interoperability platform and layer, the GraphNets, the Orions of this world have already been put in place, then it makes the job of getting the information and data shared at hub level, both for citizens and for practitioners, a lot easier.
Okay, thanks. That's helpful to hear. So we've certainly made a lot of progress around the health data. So from a medical perspective, that's a lot easier. But one of our areas of interest is bringing the local authorities into the development of integrated hubs in a very similar fashion you've just been describing. So it then raises that question that it's not medical, it's social services, it's wider community, and who should have access to that level of. So it's the ambitions raised complications, I suppose, is what I was saying. So it's just helpful to sort of test out that you've sort of gone through that same process. There is a way through it, but we're just sort of grappling with some of those challenges at the moment.
Well, look, if we can help in any way, Alex, by even if we're signposting to where we've seen around the country, everything from shared data agreements through to concordat about what health data is shared with social care and what social care data is shared with health. I can see from a number of people who are on this call have also got some insights and expertise around that. So maybe part of a community of interest around this, we could start to share some of that and point you to where people are doing that. I know a number of what were SDPs, now ICSs in English system terms, Alex, have been sharing social care data. I think the last count that there were 90 examples around the country at a shared care record level where social care data had been shared with health. If we can help in that, we will.
Great, thank you, appreciate it, thank you.
Okay, anyone got any further questions for Russ and Andy? And if not, I will hand back to Andy, who I think is going to just take us through the last 2 or 3 slides.
Okay, so this is just a wrap up. So the key thing is flexibility. The IT, the estate link, it's having control of your own life and future-proofing what you do in health and social care within your area. This is just for information, but we've basically looked at what we were planning to spend in transformational capital within one of these areas. And what we saw is there's a chunk of money there which are there for pressures. Pressures means things you can't control. You're reacting. You've lost a lease of a property. You've got a new population coming in. Those are things you have to do. They don't actually advance what you're doing as a system, but you've got no choice. And unfortunately, most of the monies are going into those sorts of activities currently. The ICS workload is what we're talking about in terms of hubs, how the spoke, how not just the hubs work, but the actual GP practices or the mental health facility, etc. works. Is putting that new sort of context in and that sort of new IT structure in. And then the final thing is simple efficiencies. Wherever you look in a system, there's obviously a few outstanding areas where you can do better, the utilization can be better, or the terms can be better than what's actually been achieved. And some of that is in definite relation to existing PFIs. Those will come back into the NHS at some stage, hopefully, and that will reduce some of the costs which are out there. Those sorts of combined events allow you to start doing some things now. That's for history. Moving on, real practicalities in terms of where estates and IT help your business case because they are coordinated. On the left-hand side, it just shows that one of the models we use, funding plays an important role, the structure of it, that's the blue box, but most important is what you do operationally and how you change operationally. And on the right-hand side, the IT estates coordination to get better value for money through operations is really those 3 blue areas, helping the co-location of the right type of organizations onto the facility. You need the IT to do that. The whole extended facilities, getting this out to people, getting this out to a spoke network and being able to share the facilities without repeat is massive. And virtual appointments and improved physical design in terms of the flow of people and how you contact with your practitioners and how you contact with your patients. Now, the big proviso I've got here is we probably rate that about 20% of the incremental change in a business case at the moment. It's important, but it's not going to carry the business case. It's the combined event of what you've got out there plus these incremental changes. However, our view, my personal view is as we start going through some of these innovations which are going to start coming through, As we go starting looking at this as a preventative facility rather than just a reactive facility, as you look at the zero carbons of the world, etc., I think the biggest contributor to a business case in relation to estates will be IT and estates working together. But certainly IT is going to drive things going forward and allow the estate to modernize in a way which is quite different from what they've had previously. So if we can move on to the final slide. We've made a couple of offers. I don't know if Russ wants to speak about these. This is basically anybody here. We're quite happy to come down and either do a benchmarking or maturity. One is related to facilities, where we'd link into IT, but it's basically looking around what you've got at the moment and the risks inherent there, and what possibly you might be able to do at a very high level in terms of getting some operational benefit from a core estate or the hubs. And the second, in terms of Socitm, Russ, can you speak to that?
Yeah, of course. So this is an established service that we've been offering to the market actually for a few years now, which is around it's assessing and helping a self-assessment where at on the kind of digital journey as an organization. And of course, when we're talking about ICSs, it's not just about one organization, it could be several. So it's a facilitated workshop. We start to look at 9 areas of best practice. It's not just about the tech, it's about how the organization is organizing themselves around that, things like governance, things like the way that they would deal with agile delivery. We've linked it to the 7 measures, and you may have seen the document come out in August, which was NHSS's What Good Looks Like. It's basically saying these are the things that characterize best practice. So we've done some linkages to that. And we'll help you raise some of the issues and surface some of the consensus about what you feel is your digital priorities. So we can start you off on that piece of assessment.
So I just come in. That's been my bit. I think Russ is going to speak about the further sessions. Thanks very much for listening, and thanks for the questions.
Yeah, this was the first of the trilogy. Sounds like Lord of the Rings territory now. This is the first of 3 webinars, one next week for those colleagues, yourselves or colleagues that might be interested in the data aspects of this. We've got a very experienced external speaker, Monica, helping us frame up some of the opportunities and challenges around sharing data. And we had a couple of questions around that. So that's the same time, but next Thursday, and then the Thursday after, it's more around the people dimension of making these systems work at a local and regional level. So we've got, again, a couple of external speakers, both working in ICSs, talking about some of the key themes around that, including trust, digital inclusion, prevention, self-care. So if those topics alongside today's are of any interest to you or colleagues, we'll be delighted to see you again.